And here are our objectives. We are going to work to understand the concept of the medical home. We'll go a little bit into the history of the medical home. We'll talk about the desirable characteristics, and then we'll talk about some challenges to implementation of the medical home. And at the end, I hope to share some resources for implementation. And then we will review some of the newborn screening process in North Dakota by going through a case study, and then also being able to learn some patient perspective on this. So every year, the American Academy of Pediatrics has some agenda that, several, usually 3 to 5 items that they are going to focus on. And between 2014 and 2015, the medical home was one of these items. And they sort of marketed it under the tagline of "Every child deserves a medical home." With gaining interest in this topic because of the changing healthcare climate, increasing healthcare costs, technology, specialization, and fragmentation of care, that's one of the reasons that it was made one of the top agenda items. And this is all pre-pandemic. As we read through the news this morning, I saw the headline of the nurses that were on strike in New York and how that's affecting medical flow. So all of these issues that were concerning 8 years ago when it was part of the American Academy of Pediatrics agenda have definitely become even higher stressors within the healthcare system. So the relevance of medical home right now is even greater than it was 8 years ago. So let's dive in a little bit to the history of this concept. So in 1967, I moved forward too quickly. In 1967, it was first documented in the American Academy of Pediatrics book on standards of child's health, defined as the central source of pediatric medical record, especially in children with special healthcare needs. I'm biased as a pediatrician, but I truly believe that if we cared for everyone and developed a healthcare system that was based off of how we believe we should take care of children for all people, then our healthcare system would be more functional and we'd all be reaping the benefits of that. So this concept moved forward in 1974 and was discussed by the AAP Council on Pediatric Practice. And they noticed that, sort of these gaps, these delays were affecting the health of children. In 1978, a pediatrician in Hawaii, his name is Dr. Calvin Sia, worked to create a comprehensive child health plan in Hawaii. And I did my residency in Hawaii, so we got to work with him. Medical home was very central to what we learned through residency because it was first sort of developed and rolled out there. And we got to work with Dr. Sia and his son, who's also a pediatrician. So in 1979, the Hawaiian legislature passed the Every Child Deserves a Medical Home Act. And then implementation in Hawaii through their Healthy Start home visitation program was implemented in 1984, and really for the purposes of prevention of child abuse and neglect. And then further funds were rolled out there. In 1992, the AAP published a policy statement defining the medical home further. And then in 1999, we saw that it, kind of broadened its reach and went through the Maternal Child Health Bureau, providing awards. In 2002, the AAP published an updated kind of medical home, an update on the medical home. In 2007, the joint principles of patient-centered medical home were published in other professional bodies than just the American Academy of Pediatrics. In 2010, it became part of the Affordable Care Act. And then in 2013, the National Center for Medical Home Implementation awarded additional 5 years of funding for that. So what is the medical home? It's really a model of delivering primary care. It is patient and family centered. It is requires a collaboration with community-based resources. It ensures appropriate payment to support and sustain optimal health outcomes. And it facilitates interdisciplinary teams of patients, families, physicians, specialists, subspecialists, hospitals, healthcare facilities, public health, and community resources. The desirable characteristics of the medical home are listed below, and we're going to go through them one by one. So it's important that a medical home is accessible. Care needs to be provided in the child's community or in a place that a child can access and a family can access. All insurance, including Medicaid, should be accepted. The practice should be accessible by public transportation. I put an asterisk here because we live in North Dakota and public transportation is hard to come by. So I do think we need to consider how some of our collaborative systems here may not be optimal for certain populations. Families or youth are able to speak directly to the physician when needed, and the practice is physically accessible and meets ADA requirements. The care should be family-centered. The medical home physician is known to the child, youth, or family. There's a mutual responsibility and trust that exists between the patient and family and the medical home physician. And the family is recognized as the principal caregiver and the center of strength and support for the child. I just want to highlight this last bullet. You know, as a physician, we go through a lot of school, a lot of training. We take care of kids that are acutely and severely ill in hospital. And we get to take care of children and watch them as they grow. But we are not the expert in another person's child. And I think that's something that we need to be conscious of and we need to be respectful of when we're engaging with families, because there is no way that that I am going to be able to provide the care to a child that they need fully all the time, right? We need to be able to communicate knowledge and support in a way that allows that child to receive the care that they need through partnership with that family. The care that we provide should also be clear, unbiased, and complete information and options are shared on an ongoing basis with this family. Families and youth are supported and they're recognized as playing central role in care coordination. And then we share this responsibility in decision-making, informed decision-making. And then just, you know, recognizing the family as being the experts in the knowledge of that child. The care should be continuous, so it should be the same primary care pediatric professionals that are caring for the child across the course of their childhood and adolescence. There should be assistance with transitions in the forms of like developmentally appropriate health assessments, counseling. We should offer these to our families, our children and families. The medical home physician should participate to the fullest extent in care, discharge planning, transitions of care, you know, receiving and giving appropriate sign-outs to physicians in hospitals, subspecialists, and receiving that back when we resume care again. The care should be comprehensive. So we should have physicians well-trained in pediatric care or providers that are being supervised by physicians well-trained in pediatric care to manage the care of children. And this is actually a separate policy statement from the American Academy of Pediatrics, especially as we run into workforce shortages. Ambulatory and inpatient care should be available at all times. Preventative care should be provided through immunizations, anticipatory guidance, regular screenings, supervision, and just safety, nutrition, parenting counseling. And then preventative, primary, and tertiary care should be offered, referred to as needed. And then the physician, through communication from the family, through partnership, through understanding, should be able to advocate for the needs of the child and family if they're not being met and they're not able to be met just through the medical system. And that's one of the main roles of the pediatrician, really, is to be an advocate for their children and families. And in a year like this year, where we have legislative session, one of the ways that we do that is through providing our perspective and our knowledge of health and development in helping to educate our legislators. The child or youth family medical, educational, developmental, psychosocial, and other needs should be identified through the medical home. That means food insecurity. It also means, recent job loss and other challenges that the family might have, and then trying to connect with additional resources. So private insurance, public resources, supplemental, SSI, Medicaid, children's health insurance programs. And I'd say, this could be improved upon. The communication between systems, especially as systems change and funding flows change, and programs get phased in and phased out. I think that as a physician, it's difficult to stay up to date on all of those changes and what things are called and who qualifies for what. So I definitely think there's room for improvement with regard to understanding the resources in the community and provided by the state that children and families have access to. And then there should be extra time scheduled for children with special healthcare needs when it's indicated. This is definitely necessary. I put an asterisk by this because, it is challenging to be able to provide adequate time to families and provide comprehensive care to each child, especially if there are specific quotas or mandates being placed on physicians or providers. So there's definitely a pull there that we need to consider in rolling out this medical care model. And the physician by themselves, I don't think can address this extra time necessary issue without looking at the whole system within which the care is being provided. So the care should be coordinated as well. A plan of care is developed by the physician along with the child and the family, and it should be shared with other places that are caring for the child. We should coordinate. So if we're referring a patient, we coordinate that referral. If the patient hasn't heard back from the physician they were referred to, their office, then we call to check to see if there was a missed number, what was going on. So the medical home should serve as the go-to point for a family if they're not sure what to do or if they're not getting the follow-up that they expected. Having a central record or database containing medical information is helpful, and that the record is accessible, but that confidentiality is preserved. The medical home physician shares information to, specialists, subspecialists, mental health providers to allow them to understand the reason for referral and the specific concerns. And then families should also be linked to additional support services through parent support groups, through like family advocacy resources, through other state programs to help support what the family's needs might be. And then we should also evaluate and review the recommendations of consultants. And I think this is really an important bullet, the second to last one on this page to consider, is that when we refer a patient to a cardiologist, and let's say this child has a referral to a cardiologist, a pulmonologist, a neurologist, a geneticist, and the family goes to all these different visits and they're being told multiple different things on what they need, what needs to be done. Sometimes some of the recommendations may be in opposition. The medical home should be able to take this information and go through it with the family to translate sort of what the recommendations are from these physicians and why, if they didn't pick it up the first time around, and then also to help the family prioritize based off of the medical needs of the child, the needs of the family, the medical priorities in the way that we should prioritize things for this specific child. It can be really overwhelming in a high needs child where there are multiple subspecialists and lots of things that need to get done. A family can really feel lost and overwhelmed by the process. And then a plan of care is coordinated to help, and then we address what additional supports we can support the family with. Care should be compassionate. So concern for the well-being of the child, the family should be expressed and demonstrated both verbally and non-verbally. My grandmother, who is not medical, would always say, you know, Kathy, it's not what you say, it's how you say it. And I think that two different physicians could say absolutely the same thing to a family, could deliver really difficult to hear news about someone's child with a different tone, and it could be received in a way that was completely different. I mean, I think we've all had these experiences. So just really trying to be present and reflective of someone else's experience when you're delivering news that's unexpected, I think is really, really important. And then efforts should be made to empathize with these feelings. I threw in another slide here about burnout and compassion fatigue. And this study was done in 2019 on pediatric emergency medicine physicians. So these are doctors that just take care of kids. And even in doctors that just take care of kids pre-pandemic, which is, you know, a different story because these numbers are going to be way higher now, they noted 16% compassion fatigue prevalence, and then a prevalence of 21% burnout, and a prevalence of only 18% of compassion satisfaction. And so when we're considering how important compassion is as it relates to the medical home, or even stepping away from the medical home, thinking just about yourself and your personal life experiences, how important compassion may have been in your discussion with a family member about something that was unexpected or unwanted, and how that compassion really helped you to feel supported rather than isolated. I think this is really, really important. And I mean, there's multiple articles now that we can read about compassion fatigue and burnout in the medical system. And obviously, I mean, with what the medical system has had to sustain as far as trauma, secondary trauma, observed trauma in the past several years has been great, but we also need to figure out a way of maintaining our ability to feel with others and to share these experiences with families. And then our medical home needs to be culturally effective. And that means that we are respectful of the cultural background, beliefs, rituals, customs of the family, and that we incorporate or consider incorporating it into the care plan. I think examples of this would be families that want to engage, some member of clergy in a medical process, whether the child is hospitalized or not hospitalized. It may be including a ritual that is part of a belief system that's different from the provider's belief system, but in a risk-benefit analysis has no risk of harm to the family. Incorporating that into the plan could really provide a great deal of resolve for that family, and also help to build a trusting relationship between the physician in the medical home and that family. And that all efforts are made to ensure that the child and family kind of understand the results of the medical encounter, the plan, and utilizing additional resources, including translators or interpreters as needed, when that would improve families' understanding. This one is not so much a cultural, but it can be challenging if there are cognitive delays in parents and you are trying to communicate a plan and helping that parent understand the plan with cognitive delays. And so there are resources as well that can help us move forward with educating parents where they are about their child's plan. And then providing written materials in a language that the family can read if they are able to read. And then this is from the National Resource Center on Family-Centered Medical Home. And this discusses health equity as another important layer to consider in delivery of an appropriate medical home. And I'm not going to go through this full slide, but I'm just going to focus on this part of the slide. So you guys may have seen this before, this graphic, but in the top part of this slide, what we see is equality, right? Every person in the top slide has a bicycle. And every bicycle on that top slide is exactly the same size, exactly the same color. But when we have different sized and different needs, needed individuals, the utility of those bicycles is going to be really different. We see that the little girl or boy over here really can barely touch those pedals and definitely can't sit while touching the pedals. And then we see that this, I think, woman sitting down over here has the bike sitting next to her, and it's not helping her move anywhere because she is not able to use these pedals the way that they're set. And when we consider equity, it's a completely different story. If our goal is to get all of these people on wheels from this part of the slide over to this part, then we need to provide them with wheeled devices that they can use. And it's the same thing for a medical home. So if you are providing all of the things we just went through for families, that does not look the same. It doesn't mean you gave them the same handout and you spoke to them the same amount of time. It means that you took the time to listen to the family's needs, assess their medical needs, help to understand their priorities, help to communicate your priorities for the child, and then provided them with necessary resources and supports for their family. I'll just briefly kind of run through these. And this was, I think in 2020, the American Academy of Pediatrics called a small work group together that included physicians that were on the Health Equity Committee at the American Academy of Pediatrics. It included 8 African-American or Black families. And then it was really a discussion about how care is provided and how provided care is perceived. And I think it was like a full day discussion. And based off of the discussion, they came up with these graphics. And some things that pop out to me is over here on the left, should is crossed out and it says, don't use this word. And I think that that's really very basic, useful information. There's a better way of saying that should or communicating that should. The importance of, feeling heard. And I think we can all relate to that. The need to transcend color. And then, listening, no judgment, authenticity. There are definitely things with regard to patient experience that came out of this small group that I think is relevant in the medical home, regardless of what population you are dealing with demographically, with regard to race or socioeconomic status or needs. And then, kind of training, check implicit bias, listen, community engagement, partnership. And so, there are barriers to implementation of the medical home. One big barrier is the training of physicians and providers to understand the medical home concept. And so that's why this ECHO is hopefully really useful for physicians and providers across the state to help to introduce the concept and provide some resources later on. Communication and care coordination for services in the healthcare system to provide family support and education or special education support. This is a challenge because they change all the time, right? And physicians aren't naturally made aware of this. I wrote Rainbow Book here because in Hawaii, there was like a binder. And I think we did have a similar resource here in North Dakota several years ago, but I don't know if it's been kind of revised and reproduced, where we could look up a specific need for a family, like medical legal partnership or food insecurity resources or parenting classes, and then we'd be able to open to all of the resources that were available and photocopy for the family and then connect them with these organizations. And over time, you learn the resources in your community, but they're definitely not exhaustive and they are changing based off of funding and programs. So we can definitely work together to improve how we become aware and access these resources. And then reimbursement for periodic well-child supervision and for care coordination is a challenge because there are stressors from above, and then there isn't always, appropriate reimbursement for taking the amount of time that is needed for children and families that have high needs. So here are some of the challenges that we can work together to advocate for and to improve for our patients and for the kids and families across the state. So now we're going to jump into our newborn screening case. Briefly, newborn screening is done to identify diagnoses in babies that could be significantly devastating or fatal if they're not identified early. And so these are typically done when baby is first born in hospital after they're 24 hours of age, and results will typically come back within 2 to 10 days. And so this case we're going to go through together, and then we will get to kind of also hear from the patient or the parent perspective in this echo, how they remember